A decision was made in 2010 to undertake a global, we call it comprehensive evaluation, to look at UNICEF's work in relation to CMAM. And the reason was fairly clear. UNICEF at that point had invested more than $100 million in CMAM-related programs, including emergencies and development contexts. RUTF was a major component, but beyond that, a lot of investment into system building, capacity building, including training, community outreach, and so on. Guidance development was also part of that. We did not have a solid evidence-based beyond internal monitoring and internal reporting of performance and learning. So the idea was that for accountability purpose, because donors want to know how things are going, also for learning, we decided to embark on a major comprehensive evaluation. Next, please. The evaluation was conducted by an external team, 2 international consultants, and then also involving national teams. Nepal was one of them. We took it as a good capacity building initiative because even in terms of methodology, we don't have many evaluations that have looked at CMAM in the way that the evaluation did, looking at the evaluation criteria of, well, impact, let's not talk about that, but at least coverage, effectiveness, sustainability, issues of scaling up very closely and going beyond that, looking at equity issues, reaching less reached. Also integration in terms of not only with Ministry of Health and national ownership, but also integration with other sectors, such as what we just heard from Nepal and so on. So it was very comprehensive evaluation, focusing a lot on learning, more in the nature of formative evaluation. We could not focus much on impact, again, for obvious reasons because of data constraints, although we very much think that in the future, the major focus will be on impact. In terms of methodology, we had to develop a generalized, what we call CMAM theory of change, evaluation framework, going from inputs, outputs, all the way to impact processes. The whole model that there are 4 different components, but then also we have other processes that are linked to it as well. So that basically guided the overall in terms of how we look at CMAM results. And then in terms of other criteria, we looked at, again, things like integration, things like equity was a major focus as well. Data collection was done. The detailed information came from 5 case studies countries. At that point, there were about 50 countries that were doing CMAM. Some had scaled up to many districts. Some were just starting in terms of not even reaching 5–6% of the affected children. But out of a sample of about 50, we chose 5 because we felt that that would at least capture 10%. And same thing was done when we went to the field sites in these countries in terms of selecting about 10 to 15% of the OTPs and so on, covering the field site too. So that was the structure in terms of sample visit. There were a lot of other sources of information, a lot of secondary data that had been shared with us through different reports, some previous evaluations, their findings, what they were saying about CMAM, also UNICEF's work, very heavy-duty desk review of existing literature, tons of interviews at the global level, national level, regional colleagues, and so on. And all of that culminated into 5 case study reports, and then 1 global report. The summary of all that is available for you to pick up in terms of this handout, but also all of this is public property for your easy download. The evaluation was not without challenges and limitations, as you can imagine, running a 5-country evaluation. Also, we also included actually a global survey with UNICEF teams, where 52 countries participated, and they were talking more in terms of experiences in working with government, working with other implementing partners, challenges in terms of reaching less reached, challenges in terms of integration, and so on too. So we took their perspective into account as well, together with the rest of the information. In terms of limitations, again, these 5 countries we are talking about, they are not exactly similar. Chad, Pakistan, Nepal, Ethiopia, all these countries are in Kenya. They are in different trajectory in terms of where they are. Data is always a problem, remains a problem even after 3 years when the evaluation has been completed. We could not compare baseline with end line and so on. Again, it was overall a formative evaluation. And we, again, the main focus here is that we could not look at impact. Some of the data that we are talking about, some of the findings even might look outdated because the actual field work was done in 2011, and a lot of learning has taken place in the last 2 years. Over to Eric.
Okay, thank you. Next slide. So I'm going to present here the key finding based on the, the 3 themes of the conference, because we have extracted from the report what is linked to the access, quality, and nutrition information. So the report is very broad. If you read, you will have more details. Please. So what are the key findings regarding equity and access? We have noticed that in all the countries, the top challenge in improving access is to identify the children we might be missed and developing strategies to reach them. How to identify them, that's the key problem. And also among different partners implementing CMAM, there is a problem of planning. They are not always planning the intervention together. So this hampers the promotion of equity and coverage, because we have to organize where they are implementing their interventions. And also in those countries, there is weak awareness of challenges in estimating geographic and treatment coverage. Please go on. And once it's come to the most effectiveness tool to improve access, we have run the internet survey in the 52 countries, and they say that to improve access, we have to invest in stronger case identification and also in mapping vulnerability in the country. And also, since community outreach is one of the components, to invest in community-based assessment for CMAM. Through this, we can improve access to the intervention. Please go on. Regarding the challenges in conducting treatment coverage, these are what we found. They are not even planned or funded for most of the interventions. And also, when they are planning to run coverage survey, some data are not available, like for some prevalences or estimation of the population. And also, in most countries, there are not people trained to run coverage surveys. Regarding the effectiveness of the intervention, we have noticed that in all countries, the capacity development has promoted the quality of services in those countries. Sensitization and also active case funding has critically improved the admission to services. So the importance of community outreach. But what's the problem? The problem for community outreach is that it is not adequately planned. It is the least developed component in the different guidelines in the countries. How to plan community outreach, how to assess the community, how to support community health workers. For outpatient services, in all countries, the cure rate is very good. In all the countries that UNICEF is supporting. But for inpatient treatment, although the health system has been strengthened, but we still have weaknesses in staffing, round-the-clock staffing, psychosocial support, data collection and analysis, and also coordination of referrals between inpatient and outpatient treatment. Regarding the quality still, what has helped to improve the quality? We have said capacity development, but we have noticed that the capacity development was based on the standards. So in most of the countries, 5 to 6 years, the development and the fact of unifying the standards, CMAM standard with other childhood development programs has helped to improve the quality in the health services, and also the improvement of national standard for CMAM. For nutrition information, one of the big issue was the reporting system among different partners. Each implementing partners has its own reporting forms. And in countries like Nepal, we noticed that the health worker in the health centers has to report for 20, has 32 forms to report every month for different organizations and for different interventions. So we have to unify these forms. And also, community outreach, as I said, there are no indicators to assess the effectiveness of community outreach in most of the guidelines. And joint planning among different implementing partners are not always undertaken, but it's effective when it is. So it's necessary to coordinate the activities. Please. These are additional conclusions that we thought it was relevant to present as well. Regarding the ownership, strong nutrition authority and nationally owned strategy for nutrition shows to be very important to support CMAM potential for long-term impact. We saw that in Ethiopia, in Nepal as well, and in Kenya. The global guidance for SAM treatment has contributed for the development of national treatment protocols in most of the countries, but there are still some gaps or some improvement to be made in terms of planning and monitoring. So the guidelines should be updated in terms of community assessment as well, in terms of equity and gender, in terms of integration. We are always talking about integration, but how to integrate, how to proceed. And also in terms of MAM management, although the cure rate is high, the relapse rate is also high. So people would like to know how to do with children when they graduate from SAM to MAM. And talk about integration, we noticed that the main challenges to integrate CMAM into national health system is about capacity. In most of the developing countries, the health system is very weak. But we have to assess the capacity and build the capacity, and also integrating CMAM with other interventions, targeting under 5 children. In terms of cost, supply, and delivery of IUTF, we have noticed that in countries where UNICEF has supported the government in the supply chain and delivery chains, it was effective because the government was stronger, especially for forecasting. And the main challenge are funding, because UNICEF is the one providing IUTF. And the procedure also for importing IUTF, because in those countries it's not already included in the national essential drugs. And regarding sustainability, in countries where there is good coordination of different implementing partners, they can organize, they can better plan how to scale up the intervention. We have noticed that in Ethiopia and also in Nepal, as you have observed. And I don't need to mention the second point because we have already discussed this this morning. And regarding evaluation studies, dissemination of lessons, is something that we have to improve. The CMAM Forum is doing good things, but at national level also, different implementing partners will share their evaluation works. Okay, so we have some key recommendation. We still have time, I think. So the key recommendation is that UNICEF should continue to invest, to support the scale up of CMAM through treatment and prevention. And prevention could be emphasized by strengthening community outreach. This is the least or the most neglected component of CMAM. And we are discussing about coverage, about access. But if the community outreach is not strong enough, we cannot improve access, we cannot improve the coverage. We are investing in a lot of health system capacity building, but where are we getting the children in the community? So, along with integrating or strengthening the health system, we should invest more in community outreach as well. So, we have discussed about MAM because there is not a joint vision about acute malnutrition. We have already mentioned here, there are different partners for the same issue, but they should have a joint vision because the relapse rate is still high the same child is coming 2 or 3 times into the program. And strengthening community outreach should be done in investing in CMAM awareness raising activities and integrating this strategy with other outreach activities already existing in the countries. In terms of coverage, we have also to improve awareness and capacity for conducting this treatment coverage service. Please. And also UNICEF should work with the government and partner to strengthen nutrition information system, decentralization of data collection and analysis at district level, and also regarding the cost of IUTF, promote national assumption of cost for IUTF and supplementary food. In countries like basically in South Asia, UNICEF is funding, and we are hoping that UNICEF will continue to support operational research to find alternative to IUTF formulas because they are very resistant to peanut-based IUTF. So these are the main key findings.